All right, welcome back to the deep dive. We love taking these complex medical topics and really kind of getting into the nuts and bolts so that you can walk away with a clear understanding of what's going on without needing that medical degree. Today, we're going to tackle something called mixed mitral valve disease.
Absolutely. It sounds intimidating, but once we break it down, it's actually pretty straightforward.
Okay, perfect. So let's dive right in.
So, the mitral valve is this really important valve in your heart. It controls the blood flow between the two chambers on the left side of the heart. And in mixed mitral valve disease, this valve has trouble both opening and closing properly.
Kind of like a door that both sticks and doesn't latch properly, right?
Exactly. So, you end up with blood leaking back the wrong way and also not enough blood getting through when it should.
Okay, that makes sense. And from the notes you've brought, it seems like we've got a ton of information to cover everything from how this is diagnosed, the investigations they do, and even the treatment options. Our mission here is to make all of that crystal clear for our listeners.
That's the goal.
All right, so let's start with the patient. How would someone with mixed mitral valve disease typically present to their doctor?
Okay, so imagine a patient coming in with a diagnosis of mixed mitral valve disease. And let's throw in a little twist. They also have atrial fibrillation. Just to be clear, though, there's no sign of endocarditis. That's an infection of the heart lining or pulmonary hypertension, which is high blood pressure specifically in the lungs.
Okay, so we've got a bit of a complicated picture. And in the physical exam, I see they found an irregular pulse. Now, that's almost like a code word for atrial fibrillation, isn't it?
Absolutely. That's when the upper chambers of the heart, the atria, they're not beating properly. It's like they're just quivering instead of contracting in a nice rhythmic way.
So that explains the irregular pulse. But I also see that the notes say the pulse has good volume and character. What does that tell us?
Well, it means that even though the rhythm is all over the place, the heart is still pumping with a decent amount of force. It's not weak or thready. And the apex beat, that spot on your chest where you can feel your heartbeat, it's not displaces, which is another good sign. If the heart was really enlarged, you might feel that beat in a different spot.
Right, that makes sense. And there's no pulmonary congestion either, meaning there's no fluid buildup in the lungs, which can happen when the heart isn't pumping effectively. So far, not too bad, but then we get to the heart murmurs, and that's where things get interesting.
Definitely. So the doctors listening to the heart heard two distinct murmurs, and they were both loudest at the apex, which is the bottom tip of the heart where you hear the mitral valve the best. The first murmur they heard was what we call a pansystolic murmur, meaning it's heard throughout the entire time the heart is contracting. That's a pretty clear sign that the mitral valve is leaking during that contraction phase.
Ah, so blood is flowing back into the left atrium when it should be going out to the body.
hmm
And that's what causes that whooshing sound we hear as a murmur.
Exactly. That's the regurgitation part of mixed mitral valve disease.
Okay, and then there's this other murmur, an early to mid diastolic murmur. That happens during the relaxation phase of the heart, right?
Yes, diastole. And that murmur tells us that the mitral valve isn't opening fully when it should, restricting the flow of blood into the left ventricle. So you've got the leaky valve during systole and the stiff valve during diastole. That's why it's called mixed.
Okay, I'm starting to see the full picture here. So we've got this valve that's both sticky and leaky, and on top of that, the atria are just kind of quivering with atrial fibrillation. That sounds like a recipe for blood clots.
Absolutely. Blood clots are a huge concern with this condition, especially with atrial fibrillation. That irregular beating can cause blood to pool in the atria, which makes it more likely to clot.
And it's not just the atrial fibrillation that's worrisome. The notes mention that any history of previous emboli, that's when a blood clot breaks off and travels, is another reason to consider anticoagulation, basically using blood thinners,
Hmm.
for anyone with mitral valve disease.
Right. And if you specifically look at mitral stenosis, a history of thromboembolic events, meaning problems caused by blood clots or the presence of a clot in the left atrium, those are red flags that make anticoagulation even more important.
So we're starting to see how serious this can be, but let's step back for a minute and talk about how doctors actually figure out that someone has mixed mitral valve disease in the first place.
Mm.
What kind of investigations are involved?
Well, it all starts with a good old-fashioned history and physical. The doctor will want to know about the patient's symptoms, of course, but also any past medical history that could be relevant. Did they have rheumatic fever as a child? Any congenital heart problems?
So looking for those clues that might point to the underlying cause.
Exactly. And then they'll typically order some blood tests, just a general workup to see what's going on. And if there's any suspicion of endocarditis, they'll take blood cultures to see if there are bacteria in the bloodstream.
Okay, makes sense. And then we move on to imaging, right? Chest X-ray, ECG, echocardiogram, those are the usual suspects. Can you break down what each of those tells us in the case of suspected mitral valve disease?
Sure. So the ECG, that's looking at the electrical activity of the heart. It can confirm the atrial fibrillation and also show if the left atrium is enlarged, which often happens with mitral valve disease.
Okay, so ECG is electrical. What about the chest X-ray?
The chest x-ray gives you a picture of the heart's size and shape. You can see if there's fluid in the lungs, which would suggest heart failure. And sometimes, if the left atrium is really big from mitral stenosis, you can even see it pushing on the bronchus and esophagus, making it hard to swallow.
Wow, so it can actually affect those structures too.
Yeah, it can. And then there's the echocardiogram, which is basically an ultrasound of the heart. This is the gold standard for looking at valves.
So they can actually see the mitral valve opening and closing and see how much it's leaking or narrowed.
Exactly. And the echo can also give clues about what caused the valve problem in the first place.
Now, even though our hypothetical patient didn't have it, the notes talk a lot about infective endocarditis. Why is that so important to consider?
Well, damaged heart valves are more susceptible to infection. So if bacteria get into the bloodstream, they can easily latch onto a damaged mitral valve and cause endocarditis. And that's where these Duke's criteria come in. They're a set of rules doctors use to diagnose endocarditis.
Okay, let's break down those criteria. There are major criteria and minor criteria. What are they looking for on the echocardiogram, for example?
On the echo, they're looking for what we call a vegetation. It's basically a clump of bacteria and other stuff that's attached to the valve. It's a pretty clear sign of infection.
And for the blood cultures, what kind of bacteria are they looking for?
There are specific ones they worry about most: Staphylococcus aureus, Staphylococcus bovis, Viridans streptococci, and then there's this group called the HACE group, which are less common but still important.
And why do they need two separate blood cultures with the same bacteria?
It's to make sure it's not a contamination. Sometimes you can get a stray bacterium in a sample, but if you get the same one in two different samples, it's more likely to be a real infection.
Okay, that makes sense. And then there are the minor criteria.
Yeah, so the minor criteria are things that could suggest endocarditis but aren't conclusive on their own. They include things like fever, other positive blood cultures that don't meet the major criteria, and echo findings that could be endocarditis but aren't totally clear-cut.
There's also something called septic emboli. What are those?
Septic emboli are little pieces of infected material that break off from the heart valve and travel to other parts of the body. They can cause infections or blockages elsewhere.
Oh, wow. So that can spread the infection.
Yes, it can. And then the last minor criterion is something called immunologic phenomena. These are basically signs that the body's immune system is reacting to the infection. You can get things like Janeway lesions, which are painless red spots on the palms and soles, or Osler's nodes, which are tender bumps on the fingers and toes.
Okay, so it's a whole constellation of findings that need to be considered together. But thankfully, our hypothetical patient doesn't have endocarditis. So let's move on to treatment for mixed mitral valve disease. The notes mention both medical and surgical options. What does medical management look like?
With medical management, the goal is to control the symptoms and prevent complications. So if the patient has fluid buildup, they'll use diuretics, which are water pills. If the heart rate is too fast, they might use beta blockers to slow it down. And they often use ACE inhibitors, or ARBs, to lower blood pressure and make it easier for the heart to pump.
So kind of like a multi-pronged approach to support the heart and manage those symptoms.
Yeah, exactly. And they'll also do repeat echocardiograms to see how the valve is doing over time. The idea is to catch any worsening before it causes major problems.
That's smart, staying ahead of it. But what about surgery? When is that necessary?
They usually consider surgery when the symptoms become severe, or if the echo shows really bad valve function, even if the person feels okay. The two main surgical options are valve repair, which is where they try to fix the existing valve, and valve replacement, where they put in a new one.
And which one they choose depends on the specific situation, right?
Yeah, it depends on things like the patient's age, overall health, and how badly the valve is damaged.
Now, something I found interesting in the notes is that usually one of the problems, either the stenosis or the regurgitation, is more prominent. So
Yeah.
one might be causing more trouble than the other.
Exactly. And it's also important to understand what's causing the valve problem in the first place. The notes talk about primary and secondary mitral regurgitation.
What's different?
Primary mitral regurgitation means the problem is with the valve itself. It could be things like wear and tear, rheumatic heart disease, a birth defect, or calcium buildup. Secondary mitral regurgitation means the valve is leaking because of problems with the structures around it, like a weakened heart muscle or blocked arteries.
Oh, so it's not the valve's fault, it's the support system that's messed up.
Right. And then for mitral stenosis, the most common cause is rheumatic heart disease, especially in developing countries. But it can also be caused by things like calcium buildup on the valve or some rarer conditions.
Okay, so we've talked about how the valve malfunctions, but how does all this actually translate to what the doctor hears and feels during the exam? Like, how does the irregular pulse connect to the atrial fibrillation?
Well, the irregularly irregular pulse is literally caused by the atria quivering instead of beating properly. It's a direct result of the atrial fibrillation.
Okay, that's straightforward. And what about the apex beat? How does that change with mitral valve disease?
With mitral regurgitation, the apex beat often shifts to the left because the left ventricle gets bigger to accommodate the extra blood leaking back in. But with mitral stenosis, the apex beat usually stays in the normal spot unless the disease is very advanced.
So that's one way to distinguish between the two. And then there are the murmurs. The murmur of mitral regurgitation is that classic whooshing sound throughout systole, loudest at the apex and often radiating towards the armpit.
And with mitral stenosis, the murmur is usually a low-pitched rumbling sound, best heard at the apex with the patient lying on their left side. You can sometimes hear this sharp opening snap sound, which is the stiff valve leaflets popping open.
Okay, so those are some key differences in the murmurs. But of course, the physical exam is just the beginning. We need those investigations to really confirm the diagnosis and see how bad things are.
Exactly. The echocardiogram is crucial, but the ECG can also give specific clues for mitral stenosis, like a certain pattern in the P wave that shows the left atrium is enlarged.
And the chest x-ray can show that enlarged left atrium pushing on other structures, right?
Yeah, it can show it pressing on the bronchus and even the esophagus.
Wow, it really highlights how connected everything is.
It does. And there's also exercise tolerance testing, which can be useful to see how the valve functions during exertion. If it leaks more or the pulmonary artery pressure goes up too high during exercise, it might be a sign that surgery is needed.
So it's not just about how they feel at rest, but how the valve handles stress.
Right. And finally, there's cardiac MRI, which can be helpful in some cases, but it's not as commonly used as echo for initial diagnosis.
Okay, so we've covered a lot. Now let's talk about long-term management. What does follow-up look like for someone with mixed mitral valve disease?
It really depends on how severe the condition is and whether they have symptoms. If someone has severe mitral regurgitation but no symptoms, they'll usually have checkups and echoes every 6 to 12 months to make sure the heart's pumping function isn't getting worse.
And if they have mitral stenosis but no symptoms?
For those patients, they also have checkups every 6 to 12 months, but the focus is on monitoring symptoms and the pressure in the pulmonary arteries. If the pressure gets too high, they might need surgery even if they feel okay to prevent complications.
Because that high pressure can lead to other problems, right?
Yeah, over time, it can cause pulmonary hypertension, which can then lead to problems with the tricuspid valve, fluid buildup, and all sorts of other issues.
Wow, so it really is a cascade of effects.
Yeah.
So to wrap things up, mixed mitral valve disease is when the mitral valve both leaks and doesn't open properly. It needs careful diagnosis with a physical exam and tests like echocardiogram. And treatment can range from medication to surgery, depending on the severity and how the person's doing.
Exactly. And I think the key takeaway here is that even subtle changes in the heart's mechanics can have a huge ripple effect on the whole body.
Absolutely. It's amazing how interconnected everything is.
Hmm.
And for our listeners who want to dig deeper, there's so much to explore about the advancements in cardiac imaging and minimally invasive surgical techniques for valve disease. It's a really fascinating field. Thanks for joining us on this deep dive.